Thank you for joining today's webinar on patient decision aids, effectiveness, certification, scaling up, presented by Dr. Dawn Stacey. Patient decision aids are effective interventions to facilitate shared decision making. They are typically written or video-based resources that provide information on options, benefits, and harms, and help patients clarify their preferences. Cochrane reviews are an excellent source for evidence for developing patient decision aids. Today we are very pleased to have Dr. Dawn Stacey with us to speak about patient decision aids. Dr. Stacey is a full professor in the School of Nursing and scientist at the Ottawa Hospital Research Institute. In 2012, her outstanding and continuous accomplishments in research were recognized when she received a university research chair in knowledge translation to patients. Dr. Stacey is a director of the Patient Decision Aids Research Group at the Ottawa Hospital Research Institute, as well as a member of the Faculty of Graduate and Postdoctoral Studies at the University of Ottawa, academic appointee at the Ottawa Hospital, and a member of the Nursing Best Practice Research Center. She won the 2009 Young Researcher Award for the Faculty of Health Sciences, and in 2012, the Canadian Association of Nurses in Oncology, the Oncology Pfizer Award of Excellence in Nursing Research. Dr. Stacey's research program is focused on advancing the science of knowledge translation to patients. The overall goal is to understand, measure, and evaluate the effectiveness of knowledge translation interventions for patients, and evaluate strategies to enhance patient engagement in sharing decision-making. Dr. Stacey lectures extensively both nationally and internationally on various aspects of patient decision support, knowledge translation, oncology nursing, and telephone consultation. She is speaking and supervising students. She is teaching and supervising students in graduate programs in nursing, population health, and clinical epidemiology. She leads the Cochrane Review on Patient Decision Aids, is a co-investigator on the Cochrane Review of Interventions to Improve the Adoption of Shared Decision Making, and co-chairs the International Patient Decision Aid Standards Collaboration, or IPDAS. Her research is conducted in Canada, the United States, Australia, the United Kingdom, and Chile. Dr. Stacey, we are very pleased to have you with us today, and now I will turn the presentation over to you.
So thank you, Eileen, for the warm invitation and opportunity to share my research with in this webinar. In my presentation today, I'm going to discuss patient decision aids. I'll talk about the evidence, talk about the proposed certification process and the international standards, and then talk about scaling up. So shared decision-making is defined as a process by which healthcare choice is made between the patient and one or more healthcare professionals. Weston has described this as really the crux of patient-centered care. And based on the Cochrane Review of Decision Aids, as well as the Cochrane Review of Interventions for Increasing Adoption of Shared Decision-Making, we know that shared decision-making can be facilitated by the use of patient decision aids, decision coaching, and in fact training of healthcare professionals. In the previous slide, I defined shared decision-making as a process, and I think it's important to think about what are the steps in that process, and they're summarized on this slide. So the first step is that we need to be clear about what's the decision that's being made. And so we know from multiple research studies that 50% of the time the patients actually didn't even know that a decision was being made. So the first step is we need to put the decision out there and discuss this is what it's focused on. Information exchange is providing exchange of information from the healthcare professional to the patient, or the patient to the healthcare professional, on what's their awareness of options and the benefits and harms of those options. And so this is really looking at the best available scientific evidence on these options and what are the features of the options as well as the outcomes of the options. The third step in the process of shared decision-making is discussing the patient's values and preferences for the different features and outcomes of options. The next step is to look also at the feasibility of these options. For some patients, some options may not actually be feasible once they realize what's involved in the different options. What's a preferred choice, and then actual choice that gets made and implemented. In the reviews that have been done on the evidence around when patients are involved in decision-making, we know that their patients experience improved quality of life, improved sense of control over their illness, and improved symptom relief. They have less fatigue, less depression, and less illness concerns. But consistently in studies, even over the last 20 plus years, all the time patients say they want to be more actively involved in decision-making. So moving on to talk about more specifically about patient decision aids. Patient decision aids are adjuncts to counseling. They make explicit the decision. They provide information on the facts around the condition, options, benefits, and harms. Many decision aids also communicate probabilities, or what's the chances of a benefit or harm occurring. Patient decision aids help patients clarify their values by providing examples of patients' experiences with different options, or explicitly asking patients to consider which benefits and harms matter most. Patient decision aids also guide in the steps of deliberating and communicating within the healthcare team. Some decision aids provide worksheets or lists of questions to consider. As Eileen mentioned, the formats for patient decision aids is printed materials, DVDs or videos, or online computer-based materials. But probably what's more important, other than the format, is that some decision aids are designed for use by patients independently prior to the consultation, and other decision aids are designed for use within the consultation. I'm just showing you an example of one of the decision aids that was developed in Ottawa around influenza or flu shots for healthcare professionals. And so in this one on the front page, you can see it defines the condition, what is influenza. It discusses the options around a flu shot versus waiting until there's an outbreak and taking medications such as Tamiflu. And then the third option being declining both flu shot and antiviral medications. The other piece that we also do in decision aids is we consider what other factors might influence a choice around allergies or other situations, conditions that may interfere with options. In the information around the options, then we present what are the chances of benefits. And so you can see here where the three options are compared around the benefits, presented narratively with words, as well as numerically with numbers, both framed positively and negatively, and a visual diagram so that you can see more easily that when people, one of the benefits of having the flu shot is fewer people in the community get the flu during an outbreak. The side effects are also displayed for studies that involved a placebo versus flu shot versus the antiviral medication, and you can compare across the different options. In terms of helping patients clarify their values, we propose a number of questions asking patients to rate how important is it for them to avoid all side effects, to avoid needles, to avoid inconvenience or side effects of taking pills, and then depending on how important each of these are, it would indicate which are the options that they should be considering. This patient decision aid was evaluated in a randomized control trial, and what they found is compared to controls, where there were 59 people in the control group, those exposed to the decision aid had higher confidence in their immunization decision and higher intent to be immunized. And so even though immunization is one of those in certain health centers where it's mandated or required, lately there's been a lot of pushback on immunization. And so when you present the facts to the patients or to the healthcare professionals and engage them in this study, they actually increase their intent to be immunized. Just to give you a sense of the Cochrane reviews the Cochrane review was first published in the British Medical Journal in 1999 with 17 randomized controlled trials, and we've consistently been updating the Cochrane review every few years. And you can see now in 2014 there's over 131 randomized controlled trials going into the current update that's underway. In 2005, we established the International Patient Decision Aid Standards Collaboration, and I'll talk a little bit about that later in the presentation. So what does the evidence show? So the last update of the Cochrane Review had 115 randomized controlled trials, and it was published in January of 2014. And we have a large team of researchers representative of multiple countries. In our PICO, it's focused on adults making decisions for themselves or a family member. The intervention is a patient decision aid about a treatment or screening decision. We compare it to usual care or alternative intervention, and then you can see the outcomes are around decision quality or decision-making process. And I will show you some of those outcomes in a minute. This Cochrane review includes randomized control trials only. What's probably also important is what we don't include in this review. And so we do not include decisions that are hypothetical about lifestyle decisions, about clinical trial entry, or about advanced directives. In terms of the intervention, we don't include interventions that are general patient education materials, interventions that promote compliance, or interventions that are around passive informed consent. So since we started this review and published in 1999, there's been over 40,000 almost 40,000 citations that have been screened. And in our last review, there was 115 trials published in 142 citations. There's many different topics in the decision aid trials. There's medical topics, which you can see the range of topics, and any of the ones highlighted in yellow or the plus ones are all the ones from the latest update of the Cochrane review. So you can see some of the newer topics is use of antibiotics for acute respiratory infection, contraceptives, coronary angiogram access. In screening decisions, you can see where prostate-specific antigen screening continues to be our #1 set of randomized control trials for evaluating patient decision aids. Now there's been 115 trials. And you can see, again, there's a range of different topics. In surgical decisions, there's a number of decisions around cancer treatment, benign prostate treatment, prophylactic mastectomy for women with who are genetic carriers for the breast cancer gene, coronary artery revascularization, and you can see bariatric is one of our newer topics, and vasectomy. And tube feeding actually is a really popular topic as well. In obstetrics, vaginal birth after cesarean has been evaluated in 2 trials of decision aids, and you can see where some of the newer topics are around embryo transplant and labor analgesia. There's decision aids and vaccine, and then other topics as well. In terms of, I defined what a patient decision aid was earlier on, but we also then look at, of the trials of patient decision aids, what features do they provide? So 100% provide options, outcomes, and implicit values clarification, because that would be the minimum they need to provide to be included in this review. 91% provide description of the clinical condition, 88% present probabilities of benefits and harms, 63% provide guidance in the steps of decision making, 59% provide an explicit values clarification exercise, like the exercise I showed you in the flu shot decision aid, and 50% use examples of others, or we often call this patient stories or patient's experiences. The outcomes that we've identified, and so I'm actually showing you the outcomes from the 2014. So for knowledge, there's a 13% higher knowledge, and it was actually 14% in the last update. And you can see the number of studies that have evaluated this outcome. We also, in the last update, did a sub-analysis of screening versus treatment decision aids, and they're more or less similar in terms of the outcome. A little bit higher improvement in knowledge in the treatment group. Where the biggest improvement that we see is more accurate risk perceptions. And so you can see here where patients have an 82% more realistic risk perception. You can see on this diagram, or on the forest plot, that everything's to the right of the line, favoring the patient decision aid. We see that this was 74% in the last update and increased to 82% in this update. So really the use of providing probabilities and evaluating their chances of risk perception is quite significant in these studies. Values-based choices. You can see here where very few studies, 13 in the last update, actually measured this outcome, and the improvement was 51%. You can see where it's still quite variable in terms of the level of magnitude of effect. And then all of the screening decision aids use the MMIC approach to measuring this. So it's a composite measure and measured in different ways. So it's not as clean or clear-cut as knowledge and realistic expectations. So these outcomes that I've just shared with you are the ones that are used to define decision quality. So improvement in knowledge, risk perception, and the match between values and choices. When we published the 2014 review, we also used the grade quality rating, and you can see here where knowledge has a high grade quality rating because it's been pretty consistent and steady across multiple studies, and then different variable levels of grade quality for the others. We also know that patient decision aids for process measures, or decision process measures, reduce decisional conflict, helps the undecided decide. Patients are less passive in decision making. So this is a really important outcome, the less passive, because we know when we ask the public, would you want to be involved in health decisions, over 90% say yes, they want to be involved in decisions about their health. But at the time of a diagnosis, particularly of something like cancer or cardiovascular disease or kidney disease, patients then say, oh, well, you're the expert, tell me what to do. But we know that with patient decision aids, that they're more likely to have a more active role in how that decision gets made. In the 8 trials that measured patient-practitioner communication, 7 showed improvement, and the 8th trial showed no difference between groups. And so we do know that it does shift into the consultation to be able to improve what happens in the discussions. Patient decision aids have the potential to reduce overuse of surgical procedures. So there was a decrease by 20% in elective surgical procedures. There was a decrease of 14% in prostate-specific antigen testing, and a decrease of 27% in prescribing of hormone replacement therapy. And the last one, these were studies that were conducted in the 90s when there was a huge pressure on menopausal women to start using hormone replacement therapy. Some of the other outcomes that we also monitor in this review is we look at adherence, and you can see where some are positive, some are mixed, but most show no difference. And we've actually just finished doing a sub-analysis of this outcome and have a paper coming out looking at some of the challenges with the way it's being measured, because it's really, in this review, it should be about adherence to the chosen option and not adherence to the drug. And so there's some issues about measurement. In the few studies that have measured health utilities, there's shown no difference between groups. In anxiety, most studies show no difference between groups, and we actually wrote a paper saying anxiety is a wrong outcome to measure. Depression, same, no difference. Regret, no difference. Length of consult, you can see where for some it's longer, or very few it's longer, for a couple it's shorter, and for most there's no difference in length of consult. And this is one of the biggest challenges with implementation and practice, is people are concerned about using the decision aid would take too long if they were to implement it in their practice. Confidence with decision making, you can see where it's either positive or no difference. General quality of life, mostly no difference, and disease-specific quality of life, generally no difference. One of the problems with the quality of life outcome is that we need to, with different options, they often have different harms associated with them. And so quality of life can be impacted whether you choose option A or B in most situations. And so we actually need to figure out quality of life measures that are more specific to matching to patient preferences and not just generically applying a quality of life measure. There's only actually one trial, the Kennedy trial, that's a true cost-effectiveness analysis, and it showed that use of decision aid or decision aid plus decision coaching was more cost-effective than usual care. The other studies that have measured, done economic evaluations haven't done a full cost effectiveness analysis. And so really at this point, we have little data indicating truly whether or not these are cost effective. If you're interested in finding a patient decision aid, if you just Google decision aid in all the countries except in the UK, we're the top on the list at the Ottawa Hospital Research Institute, where you can actually get to the A to Z inventory of available decision aids from around the world. In the UK, we're about 4th on the list, because in the UK they have a number of sites for patient decision aids that are located only within the UK. But on this one, you can find out what ones are available internationally. Also, there is another website in the Netherlands run by Pipe Stallmeyer that actually looks at decision aids from other languages, whereas ours is focused on English and French. Once you get to this, if you type in something like birth control, you can actually find out that there's 2 examples of patient decision aids that I've pulled up here. And on the quite far down, you can see it says available here, and if you click on that link, it takes you through to the patient decision aid. We also rate the decision aids in this inventory against the International Patient Decision Aid Standards, and you can see how it ranks on the criteria from the standards. So summarizing the gaps in evidence based on the most recent update of the Cochrane review, we have inadequate or no evidence on measuring informed values-based choice. So I talked about we have values choice congruence, but the true definition of a quality decision is informed values-based choice. And there's little, it's a composite measure, much tougher to measure, and pretty much no trials have been measuring this outcome. There's little or no evidence on impact on adherence, and as I mentioned, there's some issues with the way in which it's being measured. One of the most common ways it's measured is, did you forget a pill in the last week? And forgetting isn't the same as choosing or changing your mind in terms of a decision. And so we need to look at adherence as it relates to decision-making processes. Cost effectiveness, I already mentioned. Health outcomes achieved based on preferences. So these are areas where we really need further research. We need to also find out what's the added value of decision coaching, or when's it needed, because this is a component that's used in some of the decision aid studies. We need to look at the effect of decision aids on diverse groups, or ethnically diverse, as well as lower socioeconomic. And so there has been a recent study published that did a sub-analysis of trials, and in fact, this study concluded that those with lower health literacy or lower socioeconomic status actually had higher gains than people of moderate or higher literacy levels. And so there's some emerging evidence that shows that we need to make these decision aids available to everyone. There's a huge push recently to move from more complex or longer decision aids to briefer decision aids, briefer being 1 page that can be used for within the consultation, and we need to get more evaluation on how these decision aids perform versus the longer decision aids. And also reporting guidelines. One of the challenges when you read decision aid studies that are published is that the actual elements of the decision aid are not well reported. And so we're working, the International Patient Decision Aid Standards Collaboration is working on reporting guidelines right now. So I have a few slides around proposed certification based on the International Patient Decision Aid Standards. From 2003 and to present, actually, we established the International Patient Decision Aid Standards Collaboration to enhance quality and effectiveness of patient decision aids by establishing a shared evidence-informed framework for improving their content, development, implementation, and evaluation. Glenn, Elwin, and I are co-leading it with an international panel of experts in shared decision-making. The first deliverable in the IPDAS was that we developed a checklist using a modified Delphi process, but we included a range of stakeholders, including patients, policymakers, healthcare professionals, researchers, and decision aid developers. The next step is that we developed an instrument for evaluating evaluated the psychometric properties of the instrument, to actually being able to do some research on what does the impact of higher quality versus lower quality decision aids have on outcomes. Then we moved on to propose a minimal set of standards because the first checklist had over 86, I think it had 86 items. And so then we needed to figure out what would be minimal standards for us proposing for a certification process. And I'll show you those results in a minute. We then updated the evidence underlying the IPDAS checklist using knowledge synthesis and published a series of 14 papers in BMC, Medical Informatics and Decision Making that came out in November, a special issue in November of 2013. And as I mentioned, we're now working on reporting guidelines. So in terms of the, I already mentioned the objective. In terms of our original work, we worked with over 100 participants from 14 countries to establish the original IPDAS checklist, and it's published in BMJ. In terms of the dimensions of the checklist, we have some dimensions that are focused on the essential content, so information, how probabilities are communicated, how values are clarified, guidance in the process of decision-making, and then use of patient stories. We have effectiveness criteria around the decision quality and the decision-making process. And then we have other generic criteria around development process, disclosure, internet delivery, balanced presentation of information, plain language, and then up-to-date evidence. So this just gives you an example of the criteria under presenting probabilities. And so based on a systematic review that was originally conducted by Lindell-Trevena and then recently updated in 2013 by Lindell-Trevena, we know from a number of different studies that the best ways to present probabilities is using event rates, using the same denominator, same period of time, making a statement around uncertainty, using visual diagrams such as faces and bar charts, using the same scales across different options, using more than one way of viewing the probability, so words, numbers, diagrams, based on the patient's own situation, and then using both positive and negative frames. So many of these I pointed out when I showed you the flu shot decision aid, the way the probabilities were presented. So in terms of minimal standards, we took the IPDAS standards and we divided them into what were the the criteria that were required to qualify it to meet the definition of a patient decision aid. What were the criteria necessary for certification? Because if they weren't followed, there'd be huge risk of bias and potentially negatively influence people making that decision. And then the rest of the criteria we call quality criteria. So if they're done, it's a higher quality decision aid, but it would be more optional criteria. In terms of summarizing the qualifying criteria, in order for it to be defined as a decision aid, it needs to describe the health condition or the problem. It needs to explicitly state the decision that needs to be considered. It needs to describe the options available, the positive features of the options or the benefits. It needs to describe the negative features of the options or the harms or side effects. And it needs to describe what it's like to experience the consequences or have some kind of values clarification element to the decision aid. For the certifying criteria, it needs to provide equal detail for negative and positive features of options. It needs to provide citations to the evidence using high quality evidence. It needs to discuss the production or publication date of the patient decision aid. Have an update policy, so there's some commitment to those producing the decision aid to actually continue to look and see if the evidence has changed and update the decision aid appropriately. It needs to provide information about uncertainty around the probabilities and be explicit about the funding source used for its development. For screening decision aids that are focused on a screening topic, there's 4 extra criteria. It needs to describe what the test is designed to measure. It needs to discuss next steps after a positive test result or next steps after a negative test result, and then what are the consequences of detecting a benign condition. And these criteria are summarized and reported in a paper by Natalie Joseph Williams that was in Medical Decision Making in 2013. And as I mentioned, we updated the evidence underlying, and if you'd like to get access to these papers, as I mentioned, they're in BMC Medical Informatics and Decision Making, and you can find out what's the latest evidence in any of the different domains included in the IPDAS publication. So the last section that I'd like to speak about before we open it up for questions is scaling up. And the reason why I want to talk a little bit about scaling up is because now there's a number of initiatives around the world to really look at implementing shared decision-making with patient decision aids into clinical practice and into healthcare systems. And so since 2010, the Saskatchewan government in Canada has had a mandate to develop and implement a shared decision-making framework, which will inform and engage patients in decisions about their treatment options, including surgical and non-surgical decisions. And so this mandate really came from their Patient First initiative when they asked the public in the province of Saskatchewan what did they want in terms of improving the healthcare system. And they said they wanted to be more involved in health decisions. And so the province of Saskatchewan has worked within their surgical pathways to look at development of decision aids and implementation of shared decision-making to better engage patients in those decisions. In 2010, the UK brought out a mandate around improving the culture of patient safety in the NHS, and within that, it was around implementing shared decision-making and better engaging patients in decision-making. Since this announcement in 2010, the UK actually has had a huge initiative to develop a whole series of patient decision aids and implement them into the health system across the NHS. And so if you live in the NHS, it'd be good to search decision aids and look to see which ones are already existing. Because for those of us living outside the UK, we can't actually access them or know what's been developed. But I do know one example is there's one around kidney dialysis and whether to have home versus institutional dialysis. In the U.S., the Patient Protection and Affordable Care Act that came out by President Obama in March of 2010 specifically has a section on a program to facilitate shared decision-making with the use of patient decision aids. I'm just going to see. And there's other momentum going on in the U.S. The state of Washington has had consent legislation since 2007 requiring the use of patient decision aids for all elective surgical procedures. And other states have similar types of legislation requiring use of decision aids. In Australia, the main mandate of implementing shared decision making has been written in all the legislation nationally around improving health literacy. And in the Netherlands, their report is called the Patient Participation Document, where it really emphasizes the need to be better engaging patients in health decisions. So many countries around the world now have legislative documentation looking at how can we better engage patients in decisions. So one of the challenges, if you look back at the Cochrane review of patient decision aids, is many of these decision aids have been developed, but they haven't been updated or put onto public websites to make them publicly available for use in implementation. And so we, in Ottawa, led a contract with Cochrane to actually develop patient decision aids from Cochrane systematic reviews. And what we did in this study is we took the International Patient Decision Aid Standards and we created a template that would actually meet all of the standards for qualifying as a decision aid and the certification standards as well. So we created, you can see here where the title of the decision aid makes explicit the decision, the Cochrane decision aid for patients and physicians to discuss options. We provided, step one is providing basic information around their options, or the condition, why they're being offered this decision aid. Step two is what are the options. Step three is helping them consider what are the benefits and risks of each option. And so you can see in the table, it allows comparisons. And so this decision aid template was really designed to take a systematic review that's already been done and then populate it with the information from the systematic review that could then go in and inform practice. And later on in the decision aid, we actually link it to here, actually. You can see for more detail, you can link in the middle of this slide. And if you click on that link, it actually takes you to display tables for communicating probabilities using numbers, visual diagrams, and words. So that there's layers of information, but at a minimum, there's information presented on the one page to meet the minimal criteria for IPDAS. So I'd encourage you to come and review our website at the Ottawa Hospital Research Institute. We have the Patient Decision Aids Research Group website. On our website, we have on the left column, you can see patient decision aids. You can get into the A to Z inventory here. You can find out more information on decision coaching, conceptual frameworks. In the development toolkit, we actually have a training module on how to develop patient decision aids. It's all online and open access. You can link to the International Patient Decision Aid Standards. There's evaluation measures, and then our toolkit for implementation, including training materials. So I'm going to hand it back over to Elaine. And
Thank you very much, Dawn, for providing insight into the decision aids, their use, evidence for certification, and scaling up of these aids for informed healthcare decisions. Now we'd welcome you to type in any questions that you have to Dawn into the chat box, and then she will repeat the question so that it will be recorded, and then she will answer them. But while we're waiting for questions to come through, I wanted to remind you that today's webinar will be available on demand at the end of the week on Cochrane Canada's website. The link is on the screen, this next screen here. There we go. Under Training and Events, Webinars and Webinar Archive. And again, I'd like to invite you to next month's webinar on December 10th. Again, same time from 12 to 1 Eastern Standard Time on Transforming Patient Care, presented by Dr. Beverly Shea and Sandra Schmidt. But now, if there are any questions, please feel free. I do have a question. Actually, you mentioned the international decision aids and them being on the OHRI website, but then you also mentioned that the NHS, in fact, that we, are not privy to access. And I wanted to ask, why is that? Because they're usually pretty good at sharing information.
So I think that's a good question, Eileen, but I would have to ask the NHS in terms of why they're limiting access to their patient decision aids. Because we've specifically sent requests to get access to at least include them in the patient decision aid A to Z inventory, and we often can get special permission to get access for educational purposes to some of the decision aids, and so. But at this point, we haven't been able to break through and get their involvement in the broader dissemination to let people know what's going on.
Let's see. Now, does anybody have any other questions for Dawn about the process of decision aids, specific use of decision aids? Again, please feel free to type them into the chat room. I don't see anything coming through right now. All right. Okay, I guess if there are no questions, we'll wrap up today's session. And again, just a reminder for those of you who have joined late, we'll be sending a PDF copy of today's slides if you have registered, along with a short evaluation form, and we would appreciate the completion of that evaluation form, as it does help provide us with feedback and also to meet your needs. So at this point in time, I wanted to thank Dawn very